Welcome again to my lecture channel. Today I'm going to be talking about evaluating altered mental status while in the hospital inpatient. Again, I am Dr. Arinze Ikeme, and I'm going to be very quickly going through how to evaluate these cases of altered mental status from a clinical standpoint. We are going to talk about what it involves. And of course, altered mental status in the hospital, it involves an alteration in the sensorium or level of consciousness. We use acute encephalopathy a lot. Sometimes with focal neurological deficits, sometimes without. People can have neurological deficits like difficulty speaking, slurred speech, unilateral limb weakness, paresthesias, double vision, gait instability, involuntary movement, seizures. And you can also have alteration in sensorium without deficits like lethargy, poor responsiveness, somnolence, confusion, agitation, combativeness, personality changes. And the setting is always different. Sometimes you may be in the ER during a visit for an admission, could be a rapid response call in the hospital for a patient already admitted. And of course, in managing these patients, you must still give priority to the ABC of resuscitation, which is priority to the airway, the breathing, and the circulation, of course. So you don't want to neglect that while you're evaluating any kind of medical condition. They still take priority. So let's look at the causes of mental status change. This approach is in the clinical setting. This is not by no means exhaustive, but this is how we approach it in the hospital to make sure that you've reviewed all the possible differentials. So you have to think of structural causes like an acute stroke, a brain tumor, metastasis to the brain from a primary cancer, an intracranial bleed, which is a huge one, brain abscesses, just anything structural. Then you have to think of toxic causes like toxins, infections, CNS infections, and even non-CNS infections, especially in elderly patients who can have a urine infection and get altered. Medication side effects, medication interactions, recreational drugs of abuse like alcohol intoxication, heavy metal poisoning, carbon monoxide poisoning. And then we look at the metabolic causes like hypoglycemia, hyperosmolar, non-ketotic hyperglycemic states, hypoxia, CO2 narcosis for hypercarbic patients in respiratory failure, hyperammonemia in cirrhotic patients who come in with hepatic encephalopathy, uremia, hyponatremia, hypernatremia, hypercalcemia, hypermagnesemia. Hypomagnesemia, these are the magnesium ones. People usually don't suspect that, but you need to consider that. Hypothyroidism, hyperthyroidism. Before you go to the neuropsychiatric causes like subclinical seizures, post-ictal state, acute psychosis, conversion disorders, psychosomatic issues, malingering, even sometimes rapidly progressive dementia can come with an alteration in mental status, delirium on dementia. But you want to make sure that you've ruled out the structural causes, the toxic causes, the metabolic causes before you start thinking of the neuropsychiatric causes, or before you push it aside as malingering or psychosomatic. You want to make sure that you've addressed all the other possible reversible causes. So how do you evaluate a patient with altered mental status? One, again, your history taking, considering all those possible causes. You want to know the onset, if there was a trigger, if there was any new medication, recent dose increase, or interactions with medications, associated symptoms to assess if there is an infection like fever, structural causes, past medical history to assess for metabolic causes like chronic liver or kidney disease in cases of hepatic encephalopathy or uremia, exposures, drug abuse history, psychiatric history, prior episodes, you want to know this in your history, and that's why history taking is still very important, still a priority in making diagnosis in patients in the hospital. In your physical examination, of course, after your general examination, you have to do your CNS exam, looking for focal deficits, involuntary movements, needle marks in cases of drug abuse history. You can further evaluate the patient with your lab results. One of the earliest things the ER physician will do will be checking the glucose level. You want to check the vital signs, the oxygen level. Again, giving priority to your ABCs, making sure they are stable. Look at your electrolytes, the ammonia level, the urea level, the TSH, the drug screen for poisoning or overdose, arterial blood gas in cases of hypercapnia. If your suspicion is high, with a history of COPD or lung disease, lumbar puncture for CNS analysis, CSF analysis, in cases where they come in with fever and altered mental status, of course, you definitely have to do a lumbar puncture to make sure. But again, you want to go through your history taking, your physical examination, and lab results, paying attention to those structural toxic metabolic causes we talked about, and of course the neuropsychiatric causes while you take your history, physical examination, and you order your lab tests. Of course, your imaging, if there's a change in mental status, you want to get your CT head to make sure there's no intracranial bleed, which would need, emergency attention. MRI of the brain if your suspicion for stroke is high with a neurological deficit. And of course, your EEG, which you can do a routine or a continuous one, especially for patients who remain encephalopathic when you've addressed all the other possible structural and toxic metabolic causes and they remain encephalopathic. A continuous EEG might be able to make a diagnosis of recurrent or subclinical seizures, which the spot EEGs might miss, actually. And so, of course, if your hospital doesn't offer the continuous EEG, you can consider transferring to a tertiary hospital. So the take-home points in this very short lecture is, one, a thorough history and physical examination can, in most cases, reveal the primary cause of a change in mental status for most patients. In every case of altered mental status, whether they are in the ER or a response to a rapid response call in a patient already admitted, always remember the ABC of resuscitation remains priority. The airway protection, the breathing, blood pressure, the circulation. Further investigation with lab results and imaging should be channeled to identify the primary cause of the mental status change. Again, you have to think structural, toxic metabolic, and then before you go to the neuropsychiatric ones. And of course, I want to emphasize again, the neuropsychiatric causes should be considered only after reversible structural and toxic metabolic causes have been ruled out. Thanks again for this presentation. I hope it was able to help in managing these often complex patients. Thank you.